All right, recording has started. Okay.
I'm not near it.
Recording resumed.
We're recorded. That's right. Is it going to show me? I hope not.
Yeah.
Thank you. That mobile?
I have you.
Yeah. Okay.
Employee
Just
evaluation
failure. CHF. How many times in our career have we dealt with CHF patients? Hundreds and hundreds, maybe me 1,000. I mean, that's probably sound like a lot, but it's not. But what the problem is with CHF, as you can see here, this is a resting state. Systolic is actually a functioning state, if you will. But what happens in CHF, the chambers become really thick, and that doesn't allow blood to enter the ventricles, or enough blood to enter the ventricles. Wish I had something to write on, like to write. I don't know if in your in your paramedic class, you probably learned about cardiac output. Okay, not to bore you to death, but cardiac output, there's a formula. It's very simple. It's simple mathematics. It's stroke volume times heart rate. Well, a stroke volume, an average in an adult male is about 60 to 100 milliliters per injection. So you could use your pencil and paper and say, I have a heart rate of 70. My ejection fraction is 80, because that falls right in the middle. And you'd come up with, what was it, 5,600? 5.6 liters that you're going to inject in 1 minute. Okay. Well, the problem here, because the chambers are so thick, there's not enough blood, or there's a reduced volume of blood that fills the ventricle. So when it does eject, instead of having that stroke volume, the 60 to 100 mils, it might be 20 mils. So what happens though, the heart rate increases, try to maintain homeostasis, etc. But your cardiac output is only very decreased in this situation. Now, if you have a patient that the walls of the ventricles are very thin, they've lost that muscle mass for whatever reason, doesn't matter, then it's stretched and it doesn't pump. It's like a rubber band. If you take a rubber band and keep doing this with it over and over and over again, what happens? It weakens, it gets loose. And that's kind of what happens here. The volume of blood that is coming from the atria to ventricles may be adequate, okay? But it's not ejected because of those thin walls they've lost elasticity. So the stroke volume is decreased, cardiac output is decreased. And what happens in both of these cases, you have a backflow of blood. Blood has to go somewhere because it's ejected from the ventricles, does it not? Yes. Okay. What's the train of thought? It's at 7.
Just at the line board on.
Oh, I don't. Okay, let me back up. Okay. Now, there's 2 types of CHF, and that's hard to read. I can't read. I'll try to make it a little larger, but it's very difficult, and it's probably not going to. Okay, there's left-sided and right-sided. It doesn't matter to us, per se, why they're in right heart failure or left heart failure. Okay, it really doesn't. And we'll go over some of the reasons they are a little bit later, but there are some differences. If you have a patient that has right heart failure, and we know the right heart is responsible for what? Collecting not unoxygenated, but deoxygenated blood from the peripheral regions, etc. Through the inferior and superior vena cava, it comes into the right atria, does it not? Yes. Now, when blood fills the atria, you guys know that most of the blood flow from the atria to the ventricle is a passive process. Okay, it is about 80%, and it varies per patient. And then you have that atrial kick that kicks the other 15 to 20% of the blood into the ventricle, and that's both right and left atria. Okay, if you have a patient that has right heart failure, what happens to the blood because it's not adequately pumped from the heart to the pulmonary system? You start having a backup of the fluid or blood, if you will. And where does it go? It goes to the systemic region, meaning what? To the body, to the peripheral region. And what we see in those patients is pedal edema. It may be 4+. You may even see them weeping, worst case scenario. Or I'm just fat with ascites. You'll sit around their head. So if you see that, you think, okay, it's right heart failure. However, after a period of time, your patient is going to have both right and left heart failure. It just occurs. But in left heart failure, this is more of an emergency for us as providers. Because in left heart failure, since the left ventricle cannot pump effectively the blood via the aorta to the body, you start having a backup. Now, what happens, or where does it back up to? It backs up to the lung. So, and that creates a major problem. Okay. Respiratory distress. Have any of you ever seen in basic UMT classes, I this 100 years ago, all these patients in pulmonary edema have white frothy, etc. coming out?
That's pretty advanced. That's pretty advanced right there at the.
I've seen it twice in 40 years. That person is FTD. Okay, they're going to die if you don't do something rapidly. But generally, they don't let it get that bad. Generally, somebody calls 911, gives them POV, ride to the hospital. However, it is an acute finding in our presence as medics, and we know there's a treatment for it. We'll go to treatment a little later. There's a lot of controversy about treating patients with CHF with medications, with some medications, and I'll cover maybe why not. But I want your opinion also. About 10 minutes or however long it is, that's what you can talk that. If you have any questions at this point, is there anything that you've seen? I don't know if you can read that. I mean, it's pretty simplistic. I wish I'd make you guys copies. I don't know how many will be here. I don't want to kill trees. But we know what happens in right and left heart failure. Okay? I mean, it's very basic information.
So is there anything that we can do, we're talking about systemically, in the field? What can we do more of?
Well, the one thing, to be honest with you, and here's the thing, and I don't want to sound stupid, or it just sound very simple. We're always going to treat your patient's signs and symptoms, let's be honest. Now, that patient that has right heart failure may also have some left heart failure. You may hear rales, bronchi, wheezing, etc. You're going to treat your patients symptomatically. As far as what you do, they're probably going to need, I know here's what they're going to need. And now I'm going to probably contradict myself in about 10 minutes. They're going to need oxygen, obviously. They were going to. You're going to need to set
Positive pressure or?
Well, it depends. I mean, here's the thing. If it's bad enough, you're going to put on CPAP.
Right.
Okay. If they're bad enough. Right. And a lot of people, I wear a CPAP at night. Fat people have sleep apnea. That's just the way it is. But when you first use it, you feel like you're smothered. So a lot of patients don't like that. Even the very critically ill ones don't. So you have to coach them. So can you use that? Yes, of course you can.
And it's the top.
But what we want to do is give them some oxygen. Put like Digger Mountain, I don't know if you knew Digger Mountain. Throw them a handful of air. That is the way I say put them on oxygen. Use your equipment, your pulse ox, etc. An IV of oxygen. not to give blood. They don't need blood.
Yeah, that's good.
But this patient may need what? They may. It's controversial, and I'll get into that a little bit later. It's still part of your protocol. That may or may not change soon. But that's a very good question. What do you do? Well, you take care of your patient. They don't want to be flat. I've had CHF, and here's why. It wasn't because of most of the reasons it's listed, other than bad smoke, but I had a virus. Guys, nothing else matters when you can't breathe. And I could not lay down. I slept on the couch higher for a month. And being a medic that's stupid and hard-headed, I wouldn't go to the hospital. When I went to the hospital, am I boring you?
No.
Went to the hospital. You can get your ass. You took me to Baxter. You did too. Took me to Baxter. Brad Schultz was one of my medic students back in the day. He said, "You're sick." I said, "No shit." You know, well, I didn't say that, but I thought. He said, "If you'd have waited 2 days, you wouldn't have to go through all this." Really? He said, "You've been dead."
Right. Oh,
I
you
had
were
pleural
sick.
effusions, bilateral, and pericardial. It's a horrible feeling not to be able to breathe. Ejection fraction was less than 30. It's like, that boy, you have to die. But they took good care of me. I want to say that. Anyway, I got off track there a little bit.
So your end title, is that going to show much, like your CO2? Is it, if we're talking about respiratory, acidosis, alkalosis?
Right. Well, they're going to be. Here's the thing: they're going to be acidotic.
Right.
You know, obviously.
Right.
But we don't do ABGs. Do
Right.
we know that? No. But we highly suspect it, obviously. But as far as end-tidal CO2, I mean, are you going to have this patient on a nasal cannula?
Well, that's what I'm asking. I mean, is that
Yeah.
something that we're gonna be, is
It's
we
not
going
gonna
that in
hurt.
depth with them?
In this list, or
it's-
no? But
Because this is respiratory versus cardiac technically at this point in time. Unless
it's
they have a
actually, no, it's
history.
actually both. It's both. It's respiratory secondary to the CHF.
Okay.
Most times.
Yeah.
Could you do end-tidal? Sure, if you have them on nasal cannula. You're not going to have them intubated. However, I have intubated patients with CHF, and we didn't do RSI back in the day.
They begged you to probably
They
do it.
begged me to do it. That's not bullshit. Bull,
They're
must be recorded. Bull stuff. Because they want to live and they can't breathe. But anyway, it's a very good question. If you put them on a nasal cannula, use the one that gives you end-tidal CO2.
Yeah.
That would be my advice. Now, if you do intubate them or have to intubate them, obviously you're going to do an end-tidal CO2, use the detector. And I'll be very honest with you. I have maybe used those one time. They don't work like you guys do. I've used color-medic device hundreds of times. But no, then those things were not all that accurate. I didn't think.
So the end title, even if you're not using, have the patient on oxygen, so even if you can use them specifically for end title if it's nasal cannula, even if you don't need them on
Okay,
oxygen.
that's fine.
You can use it for your COPDers and other ones because it will still pick up and read because it's got the sensor in there for it. And you can actually, if you have them on a non-rebreather, you can still have that underneath your mask for the non-rebreather and stuff as well.
Whatever. And here's the thing about being a medic, and I don't mean EMTs, medics. I love working with EMTs more than medics, to be honest with you, because they don't. Well, they use the same. But here's the thing: in healthcare, EMS, not you, because you're different from the average person. A lot of them, a lot. I don't want to hurt anybody's feelings. You're on this category too. The good side. You have a lot of these people. It's not really their fault. Get out of EMT and medic school and get their license, and they have no critical thinking skills. It's not their fault. Okay. So what you said, very important. You're thinking other than just quick medicine. Okay. You're thinking. You could say it outside the box. It's the stupidest thing ever, but I'm gonna use it. You're thinking outside of that box that, hey, I can do this with a nasal cannula, even if they're on a face mask or non-rebreather, whatever.
Or even if they're not on oxygen at all, depending on what medical condition is going on with them. I had an end title of 5 on a diabetic patient who was a trauma patient because of the issues with diabetes and all the other things that were going on. Ended up with that, but because of feeling just slightly short of breath with all the other, which was induced by the trauma, wasn't because they were having cardiac. I did do for shortness of breath, 12 week, all that to go with. However, turns out it was the other unresolved issues. I mean, the trauma obviously entered that, but an end title of 5.
Well, you know, you guys are probably better than title. See, I don't know, not say maybe if you are. But what were they cooling all?
No.
They're blowing off CO2, like a lot of it.
Well, this one wasn't at that point, but respirations were more rapid than normal.
But they weren't cooling all.
No.
They weren't DKA. Okay.
Blood sugar was 300 and some odd.
That's high. I mean, I don't know my boss. That's just another diagram, and we're not even going over it. It just shows kind of the differences. in right heart failure.
It's like me when I'm getting up in the morning.
All right, signs and symptoms. These can mimic a lot of different things. You make that a little smaller, it's kind of hard to see. This is some signs and symptoms, and there's more than that. But chest pain, short of breath. Short of breath doesn't necessarily mean you have CHF, but if you, let's just say that, well, it kind of does mean that be indicative of, let's say you're putting your clothes on and you get short of breath. That's a problem. I wouldn't say you have, I'm not diagnosing, I'm not capable of diagnosing, but I'd be a little concerned.
Did you raise your hand?
He didn't raise his hand. But you can see the others, the swelling of the legs, the abdomen is down on there. Sudden weight gain. Well, okay, when they say sudden weight gain, in 30 days, you put on 15 pounds. That's a lot of weight.
But
what would tell you is that you're retaining fluid. It's all fluid. So that would be
Some breath. Wouldn't they be in a tripod position then?
Not
depends on
necessarily.
how bad it is. Not all of them are in a tripod position. If they're tripoding, they're FTDing, okay? They're trying to get all the area in that's possible. We had respiratory earlier, getting that area out. That shit ain't working. When you have so much in the tripod, stop that breathe out. But common sense, I'm not bashing around a lover to death, but common sense tells you don't do that. Sure do.
Am I?
Yep.
I said mine like that earlier. It just said bye-bye, gravel.
Good stuff. Back. That's it.
Chair for sitting around, looking around corners.
Is that the one you went down earlier?
Yeah, they're just a lot.
Yeah, old metal or new metal?
I didn't even last through the. Right here, just go right over there. Okay, I get sidetracked pretty easy.
Okay, so let me ask you this. Like, we've got a guy at Baxter over there that he is a frequent flyer. He's got CHF, we know he does. But we run on him, what, 5 South before we run on him. In that trailer, older guys in jean shorts. And every time we get there, he's tripoding and just dying for air. I mean,
Yeah.
So the first thing we do, we get into the truck, get a blood pressure, and I always throw him with albuterol. And then we open everything back up and starts breathing better. But then we end up still taking him, but he's still got that flow chest and he's just, but I mean, should I be doing that? If his pressures are good, throwing him on that albuterol?
Albuterol.
Is it shortness?
Albuterol is not gonna hurt. I mean, you know what it does? What does albuterol actually do?
Oh, who's that? It's just
It's not gonna hurt them, and it's not gonna affect the blood pressure that much. But I mean, I can't say because I'm not there. You know, I'm not one of those people that says, you tell me your story. Say, well, I'd have done this. That's BS.
Well, I mean,
I
I'm
wasn't
just,
there. I don't know.
right.
Well, the tension,
I'm not a critique.
Well, I mean, I'm just
There's nothing
saying.
wrong with that.
He
What
just
was his
starts
O2
breathing.
stat? What was his O2 stat? What was?
His O2's has always been like, when we got there at that time, he was 83, 84. And I mean, we've never, ever gotten over 91.
Yeah.
Never do. We just give him that albuterol updraft, and I'll just sit there and I'll leave that on 7, and then I'll just turn him down to like 1 or 2, just whether just like a blow by on him.
Yeah.
And he'll sat out at 90 all the way to the ER.
Well,
Then.
If it's worked, no, if it's worked in the past, then do it.
Well, I mean, it works in the past. I'm just saying
So,
that
yeah,
in the long run, am I going to come and do that? It's not going to work.
Well, then
Do something else.
Well,
You drive faster next time.
Okay. Everybody's heard of ejection fraction, right? Ejection fraction, and here, I have up here normal 55 to 70. You may go out and Google, and it says, well, it's really 50 to 70. Or you may Google, and it's like 54 to 68. But essentially, most of the information I got doing research and others is about 55 to 70 is a normal ejection, right? Okay. If you have and we don't know this unless they do an ultrasound on a patient of what the ejection fraction is, but anything less than 30, this patient's in dire straits because they're not pumping enough blood, are they? No. Very little. You're going to have it backing up to the right heart, in the pulmonary system, also into the systemic. Now, a decreased EF may be due to these things, anti-cardiac effusion, personal high blood pressure, if they've had high blood pressure for a number of years. It can cause it also to be a trauma or disease process. That's not something we're ever going to know unless we're transporting a patient that they did an ultrasound on and we're taking them to Baxter or OHC or wherever. The paperwork that we take, if they did an ultrasound, it'll have the ejection fraction on it. So when it gets down to 30 or less, that's not a good thing, obviously. I mean, it's not. They need to be on medication. They're going to be on medication. Maybe, I don't know, it could be dobutamine, it could be dopamine, it could be a variety of different medications. Okay, CHF. Well, I already said what it is.
So, question. This goes back to what we were talking about with respiratory. How you're on certain medications and how you're not on certain medications. Talking about dopamine and dopamine. Of course, you're forcing the body to do something that's naturally not supposed to be doing because you're FTB, end of life circle, or the life in tone.
Right.
Is there lasting effects, like if a person like is excessive use of like dopamine and
Those things are temporary agents. When you start, like Norepinephrine, Levophed, you call it leaving dead. Dobutamine, dopamine, there's others. Those are for short-term use. That's when a patient is FTD.
right?
And they're trying to get enough blood circulating to get the pressure up, if you will. Because these patients that are CHF, the pressure is really low. You're going to give them a fluid bolus.
Right.
Because that would be the exact opposite of what they need.
Drown them. Or,
Yes.
yeah.
So that's why they use those pressure agents for that. But nobody stays on dopamine or dobutamine for a long period of time.
So what's the typical time frame?
Now that I don't know. I would be lying to you. I don't want to lie to you. I was on. It's one of the pressures, but only for 24 hours.
So
So I don't know. It was
it's
a short period for me. I don't know about. Tasia, here's the thing about me. If I don't know, I'm just saying I don't know. But
I
I'm
would think
finding
it
out.
would be like a week or two.
I don't know, but I tell you, a good resource to ask, or I don't mind asking, is a nice ICU nurse. Because I don't know. ED nurse probably won't know. Most of them.
Didn't Rachel work ICU? I know she worked cancer.
She worked oncology, but I don't know about
Okay. Somebody,
Rachel's very good. She would probably know, but I'm not gonna lie to you, I don't know.
we got Adrian.
Okay, those are just some other things that we talked about earlier. Rapid irregular heartbeat is fairly common. A lot of times you see during atrial, if you have atrial flutter. If you're rapid, it may even be at greater than 150. Coughing, wheezing, ascites, hypotension. That is a later finding, and when you get to this point here, it's pretty critical if they're hypotensive. A lot of times, initially, they'll be hypertensive. But when it gets to this point, the body hasn't been able to compensate anymore, so the blood pressure will drop. And it's not hypovolemia, obviously. I'm not very catchy, guys. Okay, here's what we're gonna do. Here's what possibly we would do. And let's say it's patient dependent. Not everybody fits that what? That square
box.
Yeah, not everybody fits it. But if at all possible, sit your patient upright. Matter of fact, if you have them on your cot, and it's not very safe for the patient, but their legs need to be dangling if they're in acute pulmonary edema. Oxygen, high flow, you know, earlier, Rhonda's respiratory therapist, not me. But on this patient, they really need high flow. They can change that when you put it in. The books say you should. That's all I'm gonna say.
Yeah, you're just getting, gravity helps pull some of that fluid.
That's all I'm saying.
To your extremities.
Here's the thing, you want to keep your patient safe.
Right.
Your transport, well, our transport sometimes be quite lengthy.
If you,
Okay, I'm not gonna say do it or don't, but I will tell you I've done it in the past. Doesn't make it right, but could you?
I've actually had to stick one more on the captain's chair and transfer the captain's chair. And
There's nothing wrong if they
if
can
it's
tolerate
not
that.
super severe, I did have one that I had to stick a pillow underneath their legs to give it that arch, because they had the arch. They were able to tolerate it. It did get a little bit panicky right at the last. But something about it changing the position of the legs are in, so that they're straight, it's pushing that.
Okay.
Maybe you have to have a cot in
Being
your
bent
hand.
just a little bit, gives that, just that little bit, and they were
I
able to
mean, we
tolerate
hauled a
it.
lot in the captain's chair.
Yeah. That's
Put them in the captain's chair, give them a little up strap, let them sit there. and go.
You're a crash. Constantly, but it smashes in the cat. But otherwise, it's probably the safest place to have them. It's in the captain's if you're 4 point.
Just remember that.
Okay, CPAP. You guys know much more about CPAP than I do. I don't know how to use one. That's the standard now for a patient CHF that is acute CHF. IV, in there again, Lasix used to be the standard of care. Actually, the standard of care for pulmonary edema in the old days, and it had changed a lot some places, is obviously give them oxygen. You give them Lasix, and Lasix needs to be a slow push. You give them morphine, okay? And you also give them nitro. You think, what the hell? They got chest pain, why don't you give them nitro? Why don't you give them morphine?
Yeah.
What does nitro do? It dilates the coronary, cerebral, and mesenteric artery. It's going to promote cooling. Morphine also has some of those same properties. It's different. It's an analgesic, narcotic. But one thing that morphine does for these patients, it decreases the anxiety. And if you decrease the anxiety of your patient, you're going to decrease the amount of cardiology demand. Meaning they still need oxygen, but they're not in a hyper state.
They're not breathing as
But it
well.
also decreases the preload, as does nitro. So be cautious. Go by your protocols. This isn't me saying you do this. Go by your protocols. But that's what we did for years and years and years and years. It worked. There are some contraindications to giving a patient Lasix. What would you think would be some of it?
Pressure.
Okay, if your pressure, let's say I've got some case studies. If you had a patient had a pressure of 70 over 50, are you going to give them Lasix
And if you want liquid,
Are you gonna give them nitro? No. You gonna give them morphine? No. You're not. That's why you have to be able to think critically. That's why I used to, many, many years ago, I had an ED nurse, actually a friend of mine. I hadn't been out of medical school very long, maybe a couple years. Well, you guys all you did is practice cook medicine. One slap. I didn't, because I'm a nice guy. But I thought about that. But we have a protocol. Let me tell you how protocols should be written. No, really, I wrote protocols for 3 services. I'm not bragging on myself. I did. Long time ago. It's been 30 plus, 35 years ago, bro. You leave them a little vague because not everything is black and white. You should be allowed to go outside your protocol. There's something Brad and I've talked about too, Dr. Brad. You should have that critical thinking skill set. Is that, hey, this doesn't fit this, but this works. And anytime you do something proper, he's going to back you. I do know it went that well. Yep. Now, if you mess up and do something incredibly stupid, probably not. We talked about inotropic age. What does inotropy mean? Inotropic. Force. Means force. What's chronotropic?
It's time.
It's rate. Time rate. Norepic, which is the same as Levophed. Dopamine, WE. There's other meds. Matter of fact, and cheat sheet in my pocket. Because I don't really know teach much no more. I went to Oxford, graduated from there with Jethro. Also went to Eton. That means nothing. Beverly Hillbillies. Okay, there are some other drugs also, and I can't hardly pronounce. I'm on this drug. Carvedilol. Something. But that is a PO med. It's for long term. They don't really think I'm CHF, but they don't take me off it because they don't know. They'll have my place. So, fine. Norepic. I had to write this down. Because I don't remember everything. What's the dose of Norepic?
Oh, Lord, I don't know.
Somebody just give me a what? Hey, if you asked me before I wrote that, I wouldn't have a clue.
12.
Well, what? Okay.
Milligrams.
No. Well, you're gonna-
No, most of
Your
them.
patient's blood pressure should be 1,000 over 999. No, I'm not making fun. I didn't know what it was.
Yeah.
It's 2 to 4 mics per minute. It's IV infusion.
I do remember it wasn't based on weight,
No, it's not. But now,
but that's about all.
the
I
next
know.
one,
Minute.
minute.
Okay.
But now the next one, what's the dose of dopamine?
Oh,
I do know that one.
Yeah.
I didn't have to write it down.
You're talking
It's two.
You're probably gonna start at 5.
Yes.
turkey per minute.
For this problem, okay, you'd want to run it somewhere between 5 and 20 mics per kilogram per minute. You want to calculate that? We're going to put 800 milligrams in 500 milliliter bag solution, and then we're going to, no, you're going to use a chart or use your phone.
Yeah.
Because we're going to have pumps. If you had a pump,
Oh,
it'd be pumped, it would be
The
plugged in.
pump on both trucks
Our pump
actually
that
on the
works, so
primary.
Oh, it does?
Yeah.
plugged in and charged
Well,
up.
use your pump if you ever use dopamine. Let me tell you what a guy told me this, God, a long time ago. I don't care if I'm bored, I got the 4 right now, it's fine. Actually, he's one of my medic students from a long time. And he was doing some third writing. I don't remember if it's West Memphis, but it's over there somewhere. The guy was telling the guy, my student named Shane.
Oh.
He said, Shane, would. He said,
Oh,
Shane,
yeah.
he said, you don't have to worry about that calculation. Let me show you how you use dopamine because the guy needed it. He said, I just turn it up, and when I see that carotid bounding, he said, I just back off a little bit, and everything's good.
Oh.
Okay, that's probably not the appropriate thing to do. But that being said, 5 to 20 mics per kilogram per minute is open. Now, dopamine, you can also, for a dopaminergic effect, you give it a low dose of 2 to 5 mics per kilogram per minute.
So what is that, a dopaminergic?
Yeah. Huh? Look it up.
Was it you that taught that, what we used to call the 4 AM or 3 AM method, which is the clock method?
Yeah.
That works if you remember how to do it.
If you remember it 2 I call it 2 a.m. but whatever.
I can't remember, it's been too long.
Hey, you know
I
something?
used
I
that
don't
at
remember
night.
either.
And it's like, once you've done it a few times, it's simple and you're done. I mean, it's just a couple of minutes.
One thing it does. Maintains renal perfusion, amongst other things. And dobutamine, which you're probably never going to use, you may transport it to 20 mics per kilogram. So all that being said, when that carotid starts thumping, you're in good shape.
Good. Well, I think everyone here can tell you that, well, at least for me, every CHF patient I've hauled out of the ER lately has had Lasix, O2, maybe a vent, and then maybe something else.
So
Google just.
Huh?
You're a magnet.
I'm just saying that everyone you haul out, they're still treating it this way, at least in our ER.
Similar to that one.
Yeah.
2 AM method. You use that a few times.
That's one of them, but there's another one I use.
It's just pretty simple.
Google just primarily says it's more sensory. Dopamine what is the dopaminergic effect? Dopamine acts on areas of the brain that gives you pleasure, satisfaction, and motivation.
Right. That's help me with the word, endogenously. Inside the body,
Oh.
we do have dopamine.
Right.
There's dopaminergic receptor.
Right.
It does cause couldn't cause mood swings if you have a low dopamine level.
Mhm.
But the kind I'm talking about when you give a patient dopamine, it's not that region that perfuses kidney.
Okay. Okay, so that's okay.
All right, let's look at this real quick. The next two I'm gonna go over really rapidly.
Good.
I don't know what time it is. I don't.
You got the floor.
Oh, okay.
It's not quite 1:30,
Okay.
so we're good.
Who wants to read that one?
CHF case study number 1, 73-year-old male with history of hypertension.
Are we on HDF?
What is IDPM?
No, this is still. Okay, CAD is coronary artery disease, HDM hypertension, IDDM is insulin dependent diabetes for life.
Patient presents in tripod position.
Not a good thing.
So shortness of breath, respiration rates of 30, labor to wheezing, chest pain, fetal edema, swelling in abdomen, GCS of 14, rapid irregular heart rate of 144, blood pressure 80, high speed diesel.
That's the best fluid you can use in a pre-hospital setting. I had a trauma surgeon, Nasty, was from Houston, Texas. He was one of the premier trauma surgeons in the United States. It's John Holcomb. He said the best fluid you can use in a pre-hospital setting at that time, you run a lot of diesel. It's diesel. He said they don't need that normal saying. That just makes. Can I just say what he said? That just makes you shit yourself. He said lactate. This is going to cause Kool-Aid. He said use diesel. But anyway, you had this patient. Do you really need any more information? Well, no, would you like more information?
Yes.
What caused this?
And then he died. Another shot.
Well, that's my patient stuff. Had in my career, they died.
So I'm assuming with that history of more cardiac disease, you respiratory. So we're going down, which I know we're in CHF, but we were talking about presentations of both.
Right.
So we're going to go more toward the cardiac side.
I'd kind of like to know his blood sugar while we're at it.
Yeah.
No, you want one?
Nitro is going to be
138.
contraindicated because we're not at 90 systolic.
I wouldn't even use it if it's 90. I personally would not.
Oh, yeah, you're gonna
At
die.
100, well, that's what I would
100 would
prefer.
be, it's
Yeah.
over 100. I would think about it.
And he's not perfusing well anyway. Even if 80 over 50, he was perfusing it. He's got a GCS 14, so it's going to be indicative of that anyway.
Okay.
So would you go, so I would say I'm trying to figure out, even though we're going down the cardiac side, I'm trying to wager if it is actually a respiratory problem as opposed to.
both.
a
It
heart.
says what,
It's both.
Both.
But what does Trump think though in this
Doesn't
situation?
matter. What's wrong with your patient?
Can't
he
breathe.
has labor, breathing, and
So
wheezing.
He's respiratory distress.
Well,
Yes.
he's in acute, well,
What's gonna kill him first?
what's gonna kill him first is respiratory.
Okay.
Okay,
So that's what we would treat.
so, okay, respiratory rate at 30, that's pretty rapid. Now, we don't have this patient in front of us. We don't know how long this has been going on. At some point, this person is going to failure, respiratory failure. We don't want that to happen. The Tasia's right. It's kind of both. So what is gonna kill you first?
Respiratory is gonna kill him
Exactly.
first.
So what do we want to do? Well, blood sugar is fine.
138.
So it was fine. Let's just,
They
I
threw
just
that out.
made it up.
Oh.
When the rise
So-
at 4,
What do you want to do to this patient? The very first thing,
you gotta drink the rise.
think basic,
Yeah,
think basic,
so I'd say oxygen,
think basic.
Steve Safety.
support them.
Set them up right if you can. I know they're tripoding. I get that. They're trying to
I'm
breathe.
like, he's
That's
already
it.
upright,
He's upright.
but
Tripod,
quite.
you're leaning
No.
over, you're trying
I'm
to
like,
get in.
he's not quite upright.
I said, if you can.
So kind of like what I was saying.
Okay.
Calm him down.
Throw some oxygen on. You can try to calm this patient down.
It ain't gonna
It
happen.
ain't gonna happen.
But you try.
But you try, let me ask you a question. When you have a patient that's very anxious, the family's anxious, they are sick, they may not be dying, what do you try to do? Calm them down.
They are
Okay.
sweetheart,
Do you remember when I used to be a little fiery? A little bit.
Fiery? Like fiery people?
Fiery.
Oh,
Like
fiery.
you would not have liked me 30 years ago. Nobody did. Okay,
You gave me a 5-gallon bucket to sit on, so I was pretty happy.
yeah, I was actually going somewhere that, what I'm getting at, even if somebody like me from the day could be kind to people, anybody can. I had one complaint for 40 years. Should have had a bunch probably, but that can be nice to the patients for a short period of time. But you're right. Try to calm them down. That's not gonna fix this person, is it? It can help. So what, the first thing, you were right. You're right, you already sitting upright.
Well, I was just thinking,
Okay, you want to put on some oxygen, but how do you want to provide that O2 to this patient?
yeah,
Okay. All right. Tasia's already said, I think you said this. Give me credit.
I'll take credit for it.
That you would not give license to this patient.
I
You
didn't say
did.
that, but.
I thought you did.
No, she said nitro.
Yeah, no, of course
Yeah.
not. Yeah. But would you give license?
No.
No.
Because of the- right?
No. But let's say you got him on CPAP. Breathing, he's doing fine
If they call
there,
it.
if they tolerate. So let's say you take another blood pressure and that's 74 over
Get some different.
50. Then you give him an inotropic agent. Now, does that mean we will in pre-hospital setting? I'm not saying we will, I'm just saying in theory, this is probably what we should be doing. So you're not gonna fix this person, are you? But you're gonna get them to the hospital alive. And then let the smart people take care of it.
You just said we're not smart.
No.
Identify.
It should say fishbowl. We're gonna do the water.
Okay, you guys say.
No, it's like, if
Okay,
it's
what about
labor and wheezing, they're getting up.
54-year-old male, long-term smoker, hypertension, but takes no medications.
Don't need them.
Family history of CAD, has not seen primary in years, presents supine in bed, complains of difficulty breathing, well, that's fine. Fetal edema, 2+, coughing, ascites noted, blood pressure 108/66, heart rate 126, respirations 24, and wheezing, GCS 15. So he is perfusing. I didn't know that.
What would, okay, what would you do? Let's think basic.
yeah.
If I use these words, I know as an instructor, I learned as an instructor class, you should never use a curse word. But I had, and it's not applicable here, I had a doctor friend, Dr. like that.
Oh,
And he would say, Kim, we were good friends. He had that real nasal because he had a car wreck when you go. Sometimes nothing works but a good old cuss word. I don't know if that's true or not, but that's what he said. Anyway, you set them up. What would you do? What would you do next? Excuse me, that's good. That's the battery.
I put them on oxygen.
Very good. Don't know the oxygen.
And why not give them an up back?
What this man said. Give him an upgrade. Outstanding. What else do you want to do? You obviously want to have them on a cardiac monitor. That's just standard. You have an IV. Stick them. When I brought a patient into the hospital, I might not have an IV every time, but they had 2 holes in them because I stuck them twice. I wouldn't stick them more than that. Unless it's dying. So you've done. Set them up. You did what? I forgot what you did. Put on some fat, didn't you?
No, I've been wrong.
I thought you did
We got him on the albuterol.
They were on the same side.
as many as you want.
I'll be wrong.
Anyway, the chair to this point has been good. Is there anything, CPAP, is there anything else that you do for it?
We need a 12 lead.
Is there anything else that you can do for this?
So,
Good, 12 lead.
I mean, it's
Can
not.
You can consider LASIK at that point, yes.
If
so what
you-
is your most have to be at? Like,
Well, it needs to be what, for me, let me just be honest with you,
of course.
and this is just me. You may read the literature and find something totally different. I'm not giving unless it's greater than 120.
Okay.
Sorry to say.
But
Yeah.
But I mean, if you give them LASIK,
Research
they're
it.
gonna drop them.
And
You
that's
don't
what
want
it
to,
is.
another thing, what else does LASIK do?
I don't know.
You're
It
right.
gets rid of the fluid, but you get rid of what else?
Your potassium,
Your potassium,
then you can have
your
cardiac
calcium,
arrhythmias,
your
just
sodium.
arrhythmias.
Sodium and potassium are very important for heart function. So you gotta be cautious. That's why they're trying to get away from using LASIKs in the pre-hospital setting. So we
Yes, I
carry
see.
it, we still carry it.
We can't do labs, so.
No, we don't know. Yeah, but can't do labs, can't do X-ray.
Anytime with your,
Yeah.
Superman.
anytime with your
job.
wheezing,
Another
rails,
thing
anything
you
that way.
I mean, it's not a treatment by no means.
Outstanding. Outstanding.
Yes.
Yeah,
Oh, trust me.
yes.
But if you get to their house and it's sitting there, turn it on. They're gonna calm down before you go out the door.
Absolutely.
And I'm like, now you need to sleep with that when you come back. And you don't usually.
I
get
mean, my
called back.
mom had CHF and she had 2 fans blowing on her, one on each side of the bed.
Sir. I had to bring it in. Bring it in.
Know too, that we could point right there on the top. And then just blow right in the face.
You know,
All right, this is just one more. Are you tired of this? I can
No, we're
shut
good.
it down. Short breath, hypertension, COPD, illness, independent diabetes, mellitus, chest pain, severe respiratory distress, and can only speak in 2-3 word sentences. Blood pressure elevated, heart rate elevated, respiration rate elevated, rouse. These say rouse, bronchi, wheezing. They don't really use rouse and bronchi much anymore, but I'm old school. And her meds include LASIK, Venicar, which is for blood pressure, metformin, which is for what? Diabetes. And albuterol, well, you know, it's a story problem.
That doesn't mean that they used it recently though.
Exactly what you be thinking. Because if they're taking their Venicar, this is 100%. That's probably not gonna be right. That would not look like that generally.
Well, your initial blood pressure, a lot of times once you stir them around, is always higher usually, unless they're high, like super hypotensive. Your initial blood pressure is always higher, and even for giving nitro, I never go by first blood pressure
Let me
for
tell you
that
something about
reason.
blood pressure. All of you want an automatic blood pressure. And I'm not disagreeing with what you said at all. And I don't worry much anymore. But when I get a reading that looked, I'm gonna use the word bonky out.
If it looks off,
I'm not taking another automatic one.
Grab that
I'm
manual.
doing a manual one. Because I want to know what is the blood pressure actually. And I may find out, yeah, it's that. But I found out one thing in life. hopefully more than that, EMS, these automatic blood pressure machines. It's set for-
It's a-
2101 Salem first responders, I need you to head to the Bolero and Salem. Bolero and Salem have a 59-year-old female having a heart attack. They're in a white vehicle. 59-year-old female having a heart attack. Time out 1337.
Okay.
Got what?
She just finished, fueling up, so that's how she gets out of the bill.
Oh, that's good.
You know what you can do with the automatic stuff? Actually, I'll take that and get close. If it's reading correctly while you're running it, then you can almost, it won't be as accurate as doing the manual with palpation, but it gets you in the general area. I'm just saying, you can actually palpate with the automatic, and if it, you'll get sort of close. It may not be as accurate as the other, doing a manual, but you're still, it'll let you know if that top number is halfway close.
Oh, that door. Huh? It might be right.
Maybe she had a seizure.
Stroke.
We've seen a lot
They had
of
little
those.
rock all the time, it's seizures or high blood. I don't know what high blood was, high blood pressure or high glucose. Foaming at the mouth. No, CHF.
Maybe, you know, it's,
The other side of the heart failure.
Anyway,
she got a new drug deal.
let's just burst through this. This patient needs treatment. Don't they? What would you do? for this patient?
Oh,
That's right. O2.
they also, they got rails and wheezing, so they probably need a breathing treatment.
They probably
They
need
need
places, don't they?
12 leads, they need the other.
Just because it says they take this stuff, like.
It's prescribed.
Right,
Yeah.
doesn't mean they have been.
Because what their lungs sound like, and once you get the respiratory, if you get the respiratory opened up, your respiratory rate comes down, your heart rate usually also comes down, and then your pressure follows.
That's gonna help, but that's not gonna cure this person.
No, it's not gonna
in and of
cure them.
itself, but it's one of the meds that you would obviously use,
Mhm.
along with maybe Lasix, etc. Let's get out of this stuff. Well, we know that they obviously were white, they had some pulmonary edema going on. Yeah. Their pressure was high.
Could give it nitro.
Yeah, could give them nitro, absolutely, could give them all things.
But was, they also had chest pain, so nitro would have,
Yeah.
would benefit.
It would benefit them for that. Also very good. So you're thinking, instead of just listening to me rattle on, hey, Mike, use a fan. Emma's come up, David has. You. I've learned a lot from just standing here talking. My experience is different from yours. You guys have a lot of experience that I do not have. And you know things that I do not know.
Well, and some of your presentations are different. I recently had one that we got called for. It was elevated heart rate, history of heart disease. Get there, patient denies history of heart disease. They're sitting there. You can tell they're chronic COPD or they're on oxygen. They got that color like these old COPDers do, that yellowish color to the skin. Sitting there, lung sounds severely diminished up at the top, like significantly up top, severe in the middle, and nothing in the bottom third. They're sitting there 96% on the two liters they normally on a home. Move them that. Something about FC22. The distance to walk from where they were sitting, and thankfully I listened to them before then. No chest pain.
It's gonna be off to the side, my front floor, white vehicle.
So you're doing, cardiac later, more cardiac stuff, okay. I got a question I wanna throw at you, dude.
Oh, you remember?
What?
You need to write it down?
No, I think I'll remember. Just simply because it's one of those that Angie and I ran on, and I thought I knew where we were progressing on this patient, but I'm like, I never found out. And I'd just like to know if I was maybe partially right. Because we hauled them, and I'm like, I think I know where this is gonna go if something's not done. And I just, but it's not, has nothing to do with this.
Oh,
So I'll remember,
okay.
provided I'm actually here.
Somebody here will know the answer.
I
Well,
did my first time for
That's seizure.
Yes. We've
That-
only seen about 40 of those here.
So that particular patient had no wheezing, no rails to the lungs besides just being diminished like you would think with COPD, but they were severely dehydrated. Their skin was so dry, when we tried cardiac leads, it would actually suck all the liquid out of off the stickers themselves and they would fall off. So
okay.
going from the chair at 6 feet, 8 feet to the stretcher, went into full-blown tachycardia, chest pain, and severe respiratory distress, retractions in the throat and chest. Put them on an updraft treatment. By the time we get into the ambulance, retractions, everything is worse. Can't breathe in, can breathe out just fine. So nothing's working. They can breathe a little better. Albuterol finishes. They've got, you can hear up top now. You can hear moderately in the middle, but still nothing in the bottom third. And this patient at this point, their eyes are starting to do that flutter like they do right before they crash on you. Said, you've got to do something. And about that time, I'm like, well, we got to try something else. I did finally get my 12-lead read, but it looked like crap because it's got an artifact from being dehydrated. And I was like, all right, we're going to try something else. Gave nitro. Everything starts to resolve. The respirations come down. They open up. The lung sounds clear down like the bottom of the lungs. Like within a minute to a minute and a half, they went from being blood pressure at up 180s to blood pressure's coming down closer to normal. Heart rate is now no longer in the 140s. It's down in 120s. The respirations have dropped down and they're breathing normal. I get to the receiving facility, they say, nope, CHF exacerbation, or not CHF, but COPD exacerbation. I'm like, no, you're not hearing me. I sent them the 12 lead. They didn't go by it because it said demand pacing on there, because when you have a dehydrated patient, part of the time, for some reason, the cardiac monitor will pick up and it will say demand paced on there because of how somehow it confuses the signals.
I don't trust what the 12 lead says because it's right about 80 to 85% of the time. I'm reading my own 12 lead.
Well, I looked at it and said cardiac. I got there and they're like, oh no, that's just COPD exacerbation. I'm like, no, you're not hearing me. This is what happened. I was like, albuterol didn't fix the bottom of the lungs. Nitro did.
Yeah, here's the thing. A lot of times we're out there, have this patient presents like that, give them whatever we give them, whatever we do, it totally changes
What they see when we get there.
they look at when we get them to the hospital.
It even resolved the 12 lead issues and
Yeah.
stuff.
Well, I don't. I hate to critique, and I don't know who it was.
Probably.
No. Like facilities, when you take a patient there, they really need to listen to what the EMT and medic says. No, well, I mean, any of them. I've had them that didn't listen, and it's like, do you want to hear what I have to tell you? And sometimes do, sometimes they don't.
Sometimes you get those doctors who absolutely will not let you get away without hearing.
Yeah.
What was it? Jeremy Reed at OMC. He's like,
You
now
wanna do
what do
that.
you think? And I tried that more than once. I've tried to dance around the question because, and then he's like, no, what do you think? You've hauled this patient more than once. And it's like, well, crap, he actually wants to know.
I said, we've got two new ones up at OMC. That the one, he comes in, helps move the patient off the cot. He's talking to you while you're doing it. So he wants to know everything. And then Dr. Kenny's up there.
Dr. Kenny's good.
We go through the door and he's like, oh God, geez, what'd you bring now?
Yeah. Well, we're finished for this other than not giving license to every hospital thing. We've already covered that. It's a balancing act. CPAP is it more appropriate treatment? But CPAP also for management for CHF. That was a lot longer than I anticipated.
We'll take a break till 2, so about 10-minute break.
Okay, I'm gonna be honest with you. I want to do the LVAD. It's gonna take about 5 minutes.
Sure.
And I'm gonna breeze through the coronary syndrome. And what time is it now?
We got
147.
I'm sorry it took so long on that. I did
No.
not plan to do
I
that.
think we all learned.
I hate
Yes.
I don't want you to think I'm talking at you. I hate that.
No,
I hate when people
Hey,
talk.
I
at me.
left my coat, my big yellow coat at the.
You're out of
base.
luck.
Did they say I'm-
Oh, I don't know. I'm treating.
Yeah, my feelings, if you read stuff through all of it.
Thomas said, great job,
For what?
your presentation.
It was about an hour too long, but other than.
No, it wasn't. Quit doing that.
Oh, I'm
Just
quit.
yakking. I'm yakking. If I get tired, I talk too much.
Well,
If it's,
quit
if
putting
the
yourself
idiots
down.
around the table would shut up, we'd be done. You notice I'm sitting at the table myself.
The rest of these.
Those are big words.
The rest of this crew I'd expect.
Well, I can use more than 2 syllables at a time.
They've been medical all the time.
That's not what I meant.
We just tired.
Yeah, that's it. At some point you get.
You
tired.
guys should be. You work, you run and run and run.
And you're.
This year,
for
this-
about 25 years.
It's been nuts so far.
Been medical about 30 years too
I know
long.
Thomas.
Uh,
Thomas was here.
oh, no. What does it matter?
Oh, it's
Yeah.
running this year.
Oh, we, and I shouldn't say we, because I hadn't even made a call. You've done more calls this year to this point than any other year.
Really?
Yes.
Well,
I believe it.
Yes. And been running day and night.
sorry to say, Mammoth has had a lot of calls.
Mammoth has had, I know some of them are coverages. I get that.
We're at
But
21.
Mammoth has been busier than Salem.
21.
Mhm.
Y'all
More
are on
hours. You took more hours for sure. Okay.
Yeah.
Would you please, hello Terry, hope she's listening maybe.
We do not have to log everything.
Do not log, I'm going to Salem to stop. The only thing that you log are other than your runs,
That was my
a
fault.
standby, yes, or a coverage.
Yeah, that was my fault because I thought we were
That's
still
okay.
logging every
That's
time. we
okay.
turned the
So-
wheel.
But they're not wanting us to do that.
Okay.
In
Now,
reference to that, we went on that fire standby. I know
fire standby, you don't
you
do
do.
it. Sorry.
I put it in the image chain because you had me right up on the board a couple years ago that everything dispatched.
Okay, you were.
We were
That's
paid.
different. That
Okay.
is different.
Okay, so I put it in the image
Now,
chain.
Baxter won't want that run. I keep that run in a file, but you do a run on, anytime
Elite.
you're dispatched, even if you don't get out of the parking lot, you have to do a run on it. It's a, a
Okay.
cancel.
Okay.
Yes, you did right. That's different. I'm sorry, I didn't mention that.